My name is Paula Snyder. I am with NorCal and Medicus, which is a medical malpractice carrier. I'm a risk management specialist with them. This morning, as Randy said, we're going to talk a little bit about medical ethics. And one of the things that we know as risk managers is that the principles of medical ethics also overlap with the principles of risk management. And when you practice these principles, when you think about these guidelines, you can also assist in providing defensible care and reducing your liability exposure. So that's sort of where my interest in medical ethics comes in. We're going to do a quick overview of ethical principles. We're going to look at a case study this morning, sort of walking through the steps of making an ethically challenging decision. We're going to look at a couple of particularly complex ethical dilemmas. Certainly, we're not going to solve anything this morning, but we're going to look at a couple of things that you may encounter. And we're also going to take a quick look at the ways in which medical ethics and risk management overlap. So medicine, of course, is both a science. There's scientific aspects as well as an art. And both the scientific aspects of medicine and the softer art of medicine can either contribute to or mitigate your liability risk exposure. Ethics is the moral courage to do the right thing for the patient. The crux of an ethical conflict, I think, is that not everybody always agrees on what the right thing is. And that's where the conflicts and the dilemmas come into play when we talk about ethical dilemmas. Ethics doesn't dictate the practice of medicine. It doesn't dictate the care that the patient should receive. It's just a set of guidelines, a set of guiding principles, and it's typically used also as a consultative process. For most of you who work in a health system or a hospital, you're probably familiar with an ethics committee. Generally, anyone within a healthcare setting can consult and bring the ethics committee in, whether that's a physician or the primary caregiver, as well as the staff within a hospital or a health system can also involve the ethics committee. And they can offer guidance to assist physicians as well as families in some of these decision-making processes. Central to the practical application of clinical ethics is the ability to identify and analyze an ethical question and reach a reasonable conclusion and make recommendations for action. So it's not really a matter of right versus wrong, but it's finding the better or the most reasonable solution among the given options that you have. So there's 4 basic principles of bioethics, and these principles are not necessarily in a hierarchy. Generally, autonomy will generally be sort of at the top of the heap, but we'll talk a little bit about that. Autonomy is really just the guiding principle that is for the patient preference. The patient has a right to freely accept or reject a physician's recommendations. But I think autonomy is also a two-way street when we talk about ethics, because as physicians, nurse practitioners, PAs, caregivers, you also have autonomy. And you have the autonomy to act on your best judgment, how best to benefit the patient medically, and that's something that also has to be respected. So there needs to be a balance of that. Of course, physician autonomy is not the same thing as paternalism. Paternalism is merely when a physician just assumes that his or her medical judgment alone is the only thing that should determine the care. So we really do have to keep the patient preference in mind. Another bioethical principle is beneficence, and that is essentially just taking an action that benefits another person, in this case, benefiting the patient. Primarily means the duty to bring about those improvements in physical and psychological health that medicine can achieve. Another is non-maleficence, and that is essentially the do no harm part of medicine. Now, certainly there are harms and effects of treatment that can be harmful, that are unintentional. Those things have to be considered in the decision-making process. So we're all familiar with certain types of treatment that brings both short-term or long-term harm to a patient. But with non-maleficence, we're really talking about intentional harm. And the fourth principle is justice, and that's really referring to the social theories that come into play. We're talking about the attempt to distribute the benefits and the burdens of a social system in a fair and equitable way among all the participants. And, acting, basically we're talking about fairness and the fairness of the transactions. And I think this is something that sometimes is, it's kind of a difficult debate, because in some ways we're talking about spreading the available medical care across a really wide population, and how do you manage that often with limited resources and what you can do for various people. And it does become an issue when we're looking at some of these dilemmas. So from an ethical standpoint, you always have to ask, one of the first questions is, what's the goal of the treatment? There's always multiple parties involved, and so, of course, one of the questions is, what's each of these individuals' goals? Everybody's goal may not always be the same. You have a patient who has goals. You have a family. Sometimes the patient and family's goals don't coincide. And as physicians and caregivers, we also have goals with the medical treatment that we're offering. And I think your personal values get injected into what these goals are. The health system in which you practice, a hospital, they have some goals themselves. There's standards and values that health systems have, and they can sometimes be in conflict with what the patient's goals are, what the physician's goals are. So you may have a goal that you want to preserve life no matter what. But on the other hand, the goal may be that you want to, you want to just make somebody comfortable. I think sometimes as caregivers, we may feel a sense of failure if we're not able to bring a patient back to their usual health or preserve life. There's essentially three possible outcomes of treatment that you need to consider. One is to return the patient to their usual robust state of health. Essentially, we're talking full quality of life. Another goal is to return the patient to what ethicists call an acceptable quality of life. And I think this is one of the difficult issues. What's acceptable to one person may not actually be acceptable to somebody else. So you have to determine what is the patient's acceptable quality of life? What are you able to achieve? For instance, a physician may feel that sending a patient home with a feeding tube is an acceptable quality of life. On the other hand, the patient may not feel that way about going home with a feeding tube, and that's something that really needs to be determined in making those kind of decisions. And the third possible outcome would be essentially comfort measures. When quality of life or extending life really can't be achieved, then we're talking about comfort measures or palliative care. So when we look at the four principles of bioethics, autonomy, beneficence, non-maleficence, and justice, we do have to balance those. And as I said, there's not a real strict hierarchy. Most ethicists will say that autonomy does, it counts the most, that ultimately the patient's autonomy trumps beneficence and non-maleficence. However, the interest of someone other than the patient may outweigh that. For example, the interest of you as a physician or caregiver to stay within the standard of care. when you have a patient who maybe is demanding something fairly outrageous, something that's not medically necessary, you do have an interest in not being forced to participate in something that's not medically necessary, that's way outside the standard of care. So there's sometimes a balance there of, and the patient's autonomy won't always trump everything else. Generally speaking, if benefit and harm, or beneficence and non-maleficence, are equal, then generally speaking, non-maleficence will outweigh benefit. So it's sort of first do no harm comes out on top. Some other things that you need to look at is how to figure out if something that somebody wants is medically indicated. And there's some basic questions that you can look at to determine if something is medically necessary. One of those, of course, is establishing what's the medical problem. And I think this is really important when you go to make a decision involving ethics. So we're asking things like, is this acute or is it chronic? Is this an emergency, or do we have time to make a decision? Is this disease or disorder curable or not? And then when you look at the treatment, also we're looking at things like how burdensome is the treatment? What are the side effects? What is the patient likely to go through as a result of the treatment? And is the treatment that we're offering a cure to the patient, or is it merely supportive? Also, of course, so we have the goals of the treatment. What are the circumstances where treatment may not be indicated? And this has to be based on sound clinical judgment. It may be different in every case. Does the intervention that is being considered, does it improve or maintain the patient's health? Another thing that's important to look at are what are the probabilities of success of the various treatments that are available, and how can the patient benefit from the treatment that's available. So I want to take a look at an actual case study and sort of walk it through the ethical decision-making process and see how it unfolds. So in this case, we have a 47-year-old female patient with anoxic brain injury from a drug overdose. The patient was found unresponsive. It was believed that she was down about 20 minutes before EMS arrived. The patient's admitted to a medical ICU on a ventilator. She has some episodes of overbreathing. That's very minimal. We're a week into the patient being in the ICU, and the intensivist, given the amount of brain damage, does not believe that the patient will ever return to an independent state or even be moderately functional. He also believes that the patient will die quickly if she's extubated, and that's actually what he wants to do. He wants to withdraw ventilator support and allow the patient to die through the natural course. At the time of this case, the patient's listed as a full code. There's no advance directive. The personal background of the patient is that she is divorced fairly recently. She does have visitors. Her mother and her sisters are visiting her. And in this particular case, the mother's been named as a surrogate decision maker, which sort of makes this case a little bit easier because there is someone who has been specifically established to be the decision maker. That makes these cases a lot harder when you have an incapacitated patient and you can't come to a decision on who that needs to be. When the family learns of the patient's prognosis and the physician's recommendation that he wants to withdraw ventilator support, they refuse to withdraw care. They are essentially requesting additional treatment that the physician does not feel is medically indicated. They've expressed a desire actually to take the patient home and care for her themselves. So a family meeting is scheduled. They pull together the physician that's caring for the patient, and the whole clinical team, as well as the hospital's ethicist and a palliative care physician to discuss this with the family, to find out what is it that the family understands, discuss the possible withdrawal of care and the patient's code status. So we're just going to ask a series of questions based on the principles that we looked at. The first question to ask is, who are the interested parties? So who are the interested parties in our case? Obviously the patient. Patient can't speak for herself. Who else are the interested parties? There are others. The family, and frankly, even the physician. The physician is an interested party. The physician's involved in this decision. There's a conflict with what the physician wants to do. So, the physician's an interested party. We said that the mother, in this case, has been designated as the surrogate. Most jurisdictions do have a hierarchy of decision makers for adult patients who are incapacitated. It's not absolutely the same in every jurisdiction, but it's mostly the same, which would typically be a spouse, adult children, parents, adult siblings, and then often when there's none of those options available, a close friend who steps up and is willing to be a surrogate. So you do need to know in the state where you practice what that hierarchy is and who you can turn to. I happen to live in Pennsylvania, and one of the things that we have in Pennsylvania that's really nice, there actually is regulation that dictates who the decision maker should be in the case of an incapacitated patient who does not have an advance directive or a durable healthcare power of attorney. So there's actually some guidelines in Pennsylvania that can help with that. Not every state would have that, so you do sort of have to understand what the process is in the state where you practice. Certainly, as I said, physicians are interested parties. The institution, I didn't mention this, but in this case, the institution may actually be an interested party, the hospital where the patient is residing. Hospitals in this day and age, they want to move people out. They don't want to keep someone for an extended length of time. So we may have a situation here where we have a hospital that's pressuring to do something with this patient who can't benefit from extended care in the ICU. So the next step is to find out what everybody's intentions are. And this is interesting because I think sometimes we just assume that we all are looking at this from the same point of view. And that's really important. It's something that an ethics conference or consultation can help you get to. What is everybody's intention? In our case, there's different options. It may be, in this case, it appears the family's intention is keeping this patient alive at all costs. Sometimes money factors into people's intentions, whether people have the money to do what they would like to do. Reducing length of stay can factor into this. Even covering up illegal activity can factor into people's intentions for what they want for a patient. During the family meeting in the case that we're talking about, the family was asked, first they were asked to explain what they understood, and it did appear that the family understood the patient's condition, that she had minimal brainstem activity, there wasn't much likelihood that she was going to recover. And when they started looking at what the family's agenda was, what people, what it was they seemed to want to achieve, it turns out that the mother was distressed because extended family was coming in and she wanted more time for people to come in and say goodbye to the patient. And she felt that the doctors were rushing the family and not giving them an appropriate amount of time to grieve. So that's one of the things that came out in this. The ethicist explained to her a little bit about the dying process. It's not always straightforward. It's not necessarily immediate, but also that the patient could die without even being removed from the ventilator. There was no guarantee that just keeping her on the ventilator was going to keep her alive. They determined that they wanted the family to have adequate time to make a decision, to grieve, to let other family members come in. They did sort of frame this with positive language and talk about a natural death, that they would try to do things that were beneficial to the patient, that they would reduce the patient's pain and suffering, that they would continue to care for her. But that initial family meeting in the case there was no resolution reached. So we look at the ethical principles that are at stake here, certainly autonomy. In this case, the autonomy of the surrogate decision maker to say yes or no to the care that the physician is suggesting. Beneficence, does keeping the patient alive on the ventilator, does that benefit the patient? In what way does that benefit the patient? And again, I think we could debate that, but certainly without the ventilator, the patient would not breathe on her own and would most likely die. It also turned out through this discussion, they learned that the mother felt that by turning the ventilator off, they were essentially killing her daughter. And that is, it's the way that some people would feel. And so they tried to educate her, this is just the natural course that the body is taking. Non-maleficence, sort of the same thing, the mother feeling that, this was harmful if they turn off the ventilator. And again, the emphasis trying to reinforce that the hospital would continue to provide care. And I think the justice or the social benefit comes into this too, because you have a situation of healthcare dollars and resources, and how can they best be used, and does it make sense to keep this patient for a prolonged period of time on a ventilator? Certainly, they'll look at the ethical principles, what principles are in conflict, the beneficence versus non-maleficence, with the mother's belief that the physician is recommending a course that will hasten the patient's death, autonomy versus the other principles in the mother, wanting, she's putting her wishes up against what the physician feels, scientifically looking at it, doesn't make any sense. And certainly as caregivers, I think we all know we're not required to provide care that isn't medically justified, and certainly this physician felt the care that the family was demanding wasn't medically justified. So in our case study, there was a second family conference, and that involved the same people. They revisited the family's understanding of the situation. They discussed the patient's code status. They discussed the option of palliative care, and really just looked at what are the clinical options that are available, because I think sometimes you do have to lay that out, and particularly in this kind of situation, you may need to lay that out for a family. What are the options? Keeping the patient on the ventilator. What would be involved in caring for this patient at home? If this family felt they wanted to take the patient home, the family would need to fully understand what might be involved in that. What would the cost of the care be? What are the risks to the patient if they attempt to do this? Decubiti, pneumonia, aspiration, sepsis. I mean, all the risks that we're familiar with. Is admitting the patient to a long-term care or a skilled nursing facility an option? Is keeping the patient in the hospital indefinitely an option? You need to understand. You need to ensure that the family understands that whatever of these options that they might choose, it's not curative. The patient is not going to get better. She is dying. Certainly palliative care is one of the options that was available to them. And so you look at these. They approach the mother And with the caregivers and the family support, in this case, the mother was eventually able to make the decision to withdraw life support. They gave the family some time to grieve. I think they decided that a couple of days was reasonable. The family was satisfied with that. It gave them a chance to have their family members come in, and they did withdraw life support. And the patient did die very shortly after life support was withdrawn. And I think this is one of those difficult situations. The idea of withdrawing life support. A lot of people don't necessarily understand what's going on, why you're suggesting it, what's involved. So having an ethical consult or walking through some of these questions from an ethical standpoint can help with that decision. So I think this is a good point for us to talk about two especially complex ethical issues. People have really strong feelings about both of the things that I want to talk about next. I will say we're certainly not going to resolve them this morning, but I think it's important to touch on both of these things. One is really, I think, an upcoming an emerging issue that we're seeing, and the other is something that many of you are probably dealing with. So the first one I want to talk about is the concept of death with dignity laws. And in the case that we just looked at, the patient's family initially refused to go along with the withdrawal of sustaining treatment. But there are lots of situations that we encounter where patients or families even request the withdrawal of treatment, or they decide to refuse further treatment. In 1990, the U.S. Supreme Court came down with a ruling that patients or their designated healthcare agents may refuse life-preserving medical treatment, including feeding tubes. And I think in this day and age, I think that is a fairly generally accepted concept, that patients have the right to refuse life-saving treatment, and patients do that. However, federal law, we're talking federal law, does not address the concept or the question of the right to die specifically. And that has been addressed in a number of states through state law. And there's different terms that are used for this. You'll hear the term the right to die, death with dignity. On the other hand, when you read the AMA Code of Medical Ethics, the term they use is physician-assisted suicide. And in the reading that I've done on this, it seems pretty clear to me that the term you choose is actually indicative of which side of this you come down on. Because the articles and the people who are in favor of this will call it death with dignity and the right to die, and the folks that are not in favor of this will call it physician-assisted suicide. All terms and euphemisms for the same thing. The AMA Code of Medical Ethics, in part, states that allowing physicians to participate in assisted suicide would cause more harm than good. Physician-assisted suicide is fundamentally incompatible with the physician's role as a healer, would be difficult or impossible to control, and would pose serious societal risk. So I think it's no mystery where the AMA falls on this question. However, there are a number of states that actually have laws on the books. I don't know if any of you practice. Anybody here practice in any of the 6 states that are listed on the slide? I had a feeling we probably wouldn't encounter that, but that does not mean that this is not coming to a theater near you sometime soon. The 4 states that have laws on the books are California, Oregon, Vermont, and Washington. And the laws in those 4 states they're very, very similar. They've actually crafted those laws. I think Oregon was the first. Their law's been in effect since 1997. And when you look at the laws, they're all crafted in a similar way. It seems that they've kind of followed the parameters that Oregon set down. The patient does have to be expected to die within a certain time frame. In these states, it's within 6 months. The patient has to be a certain age. We're talking a minimum age of 18, a legal adult. And there are certain consent guidelines that have to be followed. All of these states require the patient to make 2 oral requests of the physician at least 15 days apart and 1 written request. So there's pretty stringent guidelines, and the physician has, frankly, quite a few hoops that he or she has to jump through to make this happen. What these laws do is allow physicians to prescribe lethal doses of medication. What these laws do not do is allow the physician to administer the medication, and they do not allow the family or friends of the patient to administer the medication, and that's important. The patient has to be capable of self-administration. So these laws do not allow someone to assist the patient to take this medication. Most of the laws specify that if the patient does go this route, the death certificate is not to say that the patient committed suicide. That's an important point. The death certificate does not say that the patient committed suicide. The laws generally require that the patient be evaluated for depression. That does not specifically mean there has to be a psych consult, but certainly from a risk management perspective, which is the way I look at these, it's probably advisable. One of the things that we've learned in just looking into these laws a little bit is that the medications that are prescribed typically have to be compounded, and they can be quite expensive. They can run anywhere from $400 to $6,000 for the dose of medication. I think that Medicaid may pay for this. I don't know absolutely, but who knows whether private insurance, I don't know if private insurance will pay for it. So if a patient chooses to do this, it may actually be outside the reach of some people. There are 2 states that by state court ruling have allowed this. This means there's no regulatory framework, but through cases that have gone to court, the court has shielded doctors from prosecution as long as they've had the patient's request in writing. One of those states is Montana, where it went the whole way to the Montana Supreme Court, and the physician was shielded. The other state is New Mexico, and that's up in the air at this point. The ruling that shielded the physician was in 2014. That was overturned in the Court of Appeals in 2015, and that essentially means the practice is now illegal in New Mexico at this time as we speak. But it has gone to the state Supreme Court, and it's expected to be decided sometime this year. So, as physicians, nurse practitioners, PAs that are practicing in the states that you're practicing in, it seems that none of you may be faced with this decision at this point in time, but it certainly could come. I think it's likely to come to the South, if ever, at late. This is a fairly conservative area. Some of the things to keep in mind about this, in the states that do allow this, no physician is compelled to participate. So as a physician, you are not required to provide this for the patient if the patient asks. And California is the law that I'm the most familiar with. In California, you are not required to tell patients that this is an option. If the patient comes to you and asks, you don't have to participate, and you don't have to tell a patient that this is an option. If you're employed or have privileges in a facility, you have to know what your facilities stand on this. Some facilities, some hospitals and health systems will take the stand that they will not participate in this, and their employees and the physicians who practice in their facilities will not participate in this. And you will need to abide by that if you're employed or as long as you're practicing in the facility. Other facilities may be silent on it. They may allow the physicians to make their own decision. The facility where you practice cannot compel you to participate in this either. So this would be something that you'll have to basically give some thought to and think about where you fall in this, where you come down, and what you would do in this situation if it does come to a state where you practice. Certainly, I think a very controversial issue that could be debated until this time tomorrow and not really resolved. One of the other issues that I wanted to talk about, and particularly considering the focus of this conference, is maternal decision-making. I think this is particularly challenging when pregnant patients refuse physicians' recommendations that aim to provide the best for both the mother and the fetus. I think we generally start with the assumption that a pregnant woman has the fetus's best interest at heart, but challenges arise. We all know patients that maybe they do have, maybe they do care, they can't help themselves, or they really don't care about the child that they're carrying. So what are some of the steps that can help you get through this situation? I think first and foremost, you need to inform and educate your patients. When you have a patient who is not following the recommendations and the treatment that you're suggesting, whether we're talking about following a diabetic diet, whether we're talking about somebody that continues to consume alcohol or use illegal drugs. They talk about directive counseling, which is not coercion, defined as counseling where the physician plays an active role, offering guidance, advice, recommendations, but not using force or threats. Certainly, I would encourage you to use referrals and consults. And when I know that a lot of you care for pregnant patients in your practice. When you care for pregnant patients, I think one of the things that you need to do is find out what services are out there, what is available in your area to your patients. Who is available that can help you get these patients to follow the advice that you're giving. And definitely use referrals and consultation. As a risk management professional, I can't stress enough the need to document. You need to document the education that you've provided the patient. You need to document that you've advised the patient to seek additional treatment, or that you've referred them for other treatment. You need to educate patients about the risk of the behaviors and document that they've been educated. And I think that another point with this is that you obviously have to be persistent. This is not a once and done lecture that you give somebody. You have to be persistent. You have to continually reinforce what the patient needs to be doing. It's pretty much an ongoing process. And essentially follow the guidelines for ethical decision making. So what do we do when the patient continues down the path that you know or believe could harm the child? Where are you going to go from here? And this is where I think the debate gets really heated, as these debates often do. And it brings us to a discussion of court-ordered intervention as one of the options that is available. I think this is a highly controversial topic, sort of like the right to die issue. It is generally addressed on a state-to-state basis. You can find lots of articles online now discussing court-ordered intervention, arrests of pregnant women, arrests of women who have recently given birth. And they're sort of all over the place when you read the articles. One thing that you have to be really careful of when you're reading these things in news articles, finding this stuff on the internet, is that you're never getting the full story. You're only getting what somebody has reported in that article. The results are all over the board. Sometimes there's court-ordered intervention, and there ends up being a good outcome. Sometimes the outcome isn't good anyway. Sometimes the pregnant patient will, the court will refuse to intervene. There'll still be a good outcome. So it's really hard. There's not anything really conclusive that would say getting the courts involved will protect this fetus. There was a 1990 decision in the District of Columbia appellate court that has, up until more recently, been relied on, that basically said that in virtually all cases, the question of what is to be done is to be decided by the patient, the pregnant woman, on behalf of herself and the fetus. And I think most ethicists typically agree that the pregnant woman's informed refusal of medical intervention ought to prevail. I would encourage you, if you care for pregnant patients and you haven't done this, to read the ACOG opinion on refusal of medically recommended treatment during pregnancy. The website is up here online, so if you have not read this, I would definitely encourage that. The ACOG opposes the use of coerced medical intervention for pregnant women, including the use of courts to mandate medical interventions for unwilling patients. When I was researching this, I found a really interesting study that was done in 2013. It was published in the Journal of Health, Politics, Policy, and Law. And the authors were able to identify 413 cases in which there had been court intervention. Now, the difficulty in a study like this is that there's no single database. There's no one place that we can go and find all of these. But they were able to identify 413 cases. Some of the statistics that in the study, 56% of the cases, let me back up a little bit. In looking at this, they divided the country into 5 sections. So they had northeast, southeast, they had the central part of the country, and then they had northwest, and then they had Pacific Southwest. So there were 5 sections of the country. 56% of the cases that they found happened in the southeast for court intervention. 71% of the women in these cases were represented by what they call indigent defense, which essentially reflects a lower socioeconomic class. 84% of the cases mentioned the use of illicit drugs. So that seemed to be, by and large, where court intervention was sought. 84% of the time, it involved the use of illicit drugs. One of the things that I thought was interesting, and I wish I don't have a graph that would show this, so I'll try to explain the results. This study encompassed 30-some years, from 1973 to 2005. So that's, I believe, a 32-year time period. The first 16 years, they found an average of 2.5 to 3 cases per year of court intervention. In 1989, 90, and 91, right smack in the middle of the study, they found an average of 40 cases a year of court intervention. And then that leveled off for the last 14 years of the study, so 92 to 2005, where it leveled off to an average of 16.5 to 17 cases per year of court-ordered intervention. And I thought that was pretty interesting. Any idea, any thoughts about what happened right around 1990 that seemed to change the attitude about this? Anyone? Okay, I have 2 theories. One actually is something that ACOG has suggested, and that is that around the time frame of 1990, that is when fetal surgery became a much more widespread option. And they're sort of speculating that that fueled a movement that we seem to have in this country now, where a fetus is considered a person with its own rights and protections afforded under the law. Prior to that, when fetal surgery was rare and not often performed, that was not the attitude But that has become the prevailing attitude, and I think that may well have had an effect on what seemed to change around that time of 1990. I also have a personal theory that may come into play here. I have no way to test this, and certainly no scientific basis, but I do know that in around 1990 is also when we have seen the expanding use of opioids in this country, and the beginning of the problems of drug addiction with prescription opioids. And I think that we're certainly, in this day and age, seeing more and more pregnant women who are probably coming to you with opioid addictions. And I think that may also be a factor, and especially when you look at the study, although it was limited, where 84% of the cases of court intervention do mention the use of illicit drugs. So I think that this is not something where, one of the issues with ethics, there's no right or wrong answer. I will not stand up here and say you should or you should not. I think this is something that you have to answer for yourself. Is this an avenue that you would go down? I think this is not something that you have to navigate alone. Tap into the ethics committee in the health system or the hospital where you practice. Get some assistance with this. Certainly use referrals and consults with these kinds of patients, but it's definitely something that you need to give some thought to. I won't put you on the spot and ask for, whether anybody has had to, has felt that they had to go down this road, or even if you think that you would, if it came to that. But it's certainly something that I think you need to give some thought to, and how you would handle it. They get ugly. They get really ugly, some of these cases, but, and they have a variety of outcomes. They don't all have good outcomes, even when the court intervenes, and I think that is an important issue. And, one of the articles I found made the statement, and I couldn't really verify this, but that South Carolina was actually the first state in which a woman was convicted and sent to prison for murder for the death of a fetus. The woman was a drug user. I also found a fair amount of follow-up articles in which her sentence was commuted and her conviction was thrown out. I just had a hard time really verifying what happened in the case. And one of the things that in the study that I also thought was interesting was that there were pockets in different places where there were just tons and tons of these cases. So it almost seems like there's maybe a jurisdictional attitude. They found some institutions that had very high numbers of these kind of cases. They found them clustered around, say, a few counties in a state, that kind of thing. So there, it may just be that, there is just sort of a belief, a value system that, where this is more likely to happen. So I want to close just very briefly to touch on the ways where ethics and risk management overlap. Ethics is pretty much what you should do. The law is what you have to do. Risk management is what you choose to do. So they're different, but they do overlap. And I think that, as I said at the beginning, unresolved moral issues or ethical issues in patient care, those are actually the places where your potential liability exposure lies also. And what we see is that resolving the clinical ethical issues in this, using these guiding principles is a means for reducing the overall risk of a lawsuit. And that, from a risk management standpoint, that's one of our goals. Patient safety, providing the best care, and reducing the risk of a lawsuit. Some of the ways that risk management and ethics overlap, Operational issues, there's overlap, things like conflicts of interest, privacy and disclosure, allocation and utilization of resources. I want to talk a little bit about decision-making and consent. I'll just elaborate a little bit on this. Legal competency is the legal authority to exercise decision-making. Competency is typically determined by a court. Capacity, on the other hand, is specific to an instance, and a patient's ability to consent or refuse consent can be circumstantial. So you may have a legally competent patient who may not have the capacity to consent in a particular situation because of the factors of the moment. And I think those are probably some of our most difficult situations when we're talking about the idea of decision-making and consent. As physicians and caregivers, you can determine capacity. You don't determine competency. That's typically determined in court. But you can determine capacity in the situation, and it's done through an assessment of the patient, talking with the patient, observing the patient's behavior, even talking with third parties, the other caregivers, members of the family, to determine the situational capacity. It's specifically the act of comprehending, evaluating, and choosing among the realistic options. One of the things we observe is that generally a patient's capacity doesn't come into question until they disagree with the physician. Then often we start questioning, does the patient have the capacity to make the decision? Generally speaking, when a patient has capacity, their decision should be honored. Certainly advanced planning is very important, and the extent to which you can encourage your patients to do some advanced planning to determine who they want to be a surrogate decision maker should they become incapacitated. That's very important. There are all manner of surrogate decision makers. Patients have advanced directives and living wills, durable power of attorney for health care. But you can also have patients who have given their physicians a directive, put something in writing, and those, again, it does depend on your jurisdiction and what the regulations are in the state where you practice, to what degree you can depend on those. Surrogates essentially are someone who can speak on behalf of the incapacitated patient. And one of the problems when you can't come to a agreement on a surrogate is that having someone declared incompetent and having a guardian appointed is not a quick process. You can pursue that in an emergency, but it typically takes a while. It takes at least a couple of months. There's money involved because attorneys are typically involved, so somebody has to pay for that. From a risk management perspective, we do not typically recommend that the physician pursue that. I think it's an area that, as a physician, you probably don't want to get involved. Most states do not permit physicians to be named as the surrogate decision maker. Some states permit a physician to be named, but it cannot be the physician who is caring for the patient. So that's something that you need to keep in mind. If you are the attending, if you are the physician who's caring for the patient, you are most likely not going to be the appropriate surrogate decision maker for the patient. There needs to be somebody else involved in that decision-making process. Just a couple other ways in which ethics and risk management overlap. Certainly clinical questions, curative versus futile treatment, and pain management, frequent admissions, noncompliance. And I think sometimes these include concerns about lawsuits, allegations of medical negligence, This is where weighing the patient's autonomy and the physician's autonomy sometimes becomes a factor. End-of-life questions, both ethical issues and risk management issues, as well as just communication in general. So certainly resolving these ethical dilemmas by following the principles that we talked about and that we discussed can help protect you from allegations of medical malpractice and decrease your liability exposure.